Hello, everybody, and welcome. In this session, we are a focus on launching a global cholesterol action plan. And so we're delighted to be setting out this brand new plan that we hope will lead to change because it's an action plan. And we'll be setting out the different goals and activities that are meant to deliver that change. So our first speaker who is going to present to us the action plan and take us through it is Dr. Sean Goodman, who's the Associate Head of Cardiology at St. Michael's Hospital in Toronto, Canada, who's also joining us at a very early time in his morning. Welcome, Sean. Thank you so much for being with us. We're delighted to hear and to share with you in the launch of the Global Cholesterol Action Plan. The floor is yours.
Thank you very much. And thank you to Neil and the entire team for the opportunity to share a little bit of background on cholesterol and its role in atherosclerotic cardiovascular disease. That's a bit of a mouthful, so we sort of shorten that up with an acronym and we say ASCVD. So first of all, cardiovascular disease accounts for approximately 1/3 of all deaths globally, and it is the leading cause of mortality across the world. And to put this into context, even over the past couple of years, when we've all suffered through this terrible pandemic, cardiovascular disease still accounted for 2 times as many deaths as COVID-19 did. And unfortunately, cardiovascular deaths, in particular from cardiovascular disease, are increasing over the past 15 years and are expected to rise even further. Now, most cardiovascular disease and more than half of cardiovascular disease-related deaths are caused by something called atherosclerosis, sort of a hardening of the arteries. And I'll show a picture of that a little bit later on and explain it in a little bit more detail. But to just sort of emphasize the gravity of the situation and put things in perspective, in the last sort of minute, when I've been sharing the first couple of slides of my presentation with you about cardiovascular mortality, approximately 34 people have died from a heart attack or from a stroke. Now, some risk factors for ASCVD are not modifiable. For example, a premature family history, including an inherited condition called familial hypercholesterolemia, or FH, which can occur as frequently as 1 in 250 people. Other non-modifiable risk factors include older age and sex, with women apparently somewhat protected earlier on by hormones prior to menopause, but unfortunately they do catch up to men as they get older with respect to the risk of developing and dying from atherosclerotic cardiovascular disease. Now, of course, we can't change the family that we've been born into or the genes that we've inherited, but the good news is that up to 80% of premature cardiovascular events can be prevented. And this includes by lowering unhealthy levels of cholesterol, a dominant but modifiable risk factor for ASCVD. Indeed, unhealthy levels of cholesterol are considered the most common modifiable risk factor within our control for ASCVD. And there are several others that are listed here. And collectively, these risk factors account for more than 90% of all of the population attributable risk from atherosclerotic cardiovascular disease. Now, just a little bit of background on cholesterol, which is also known as lipid in the medical terminology. This is a soft, waxy substance that's made by our bodies. It's one of the lipids or fats is in fact normally found in the blood and in every cell of our bodies. Cholesterol is a vital building block of cell membranes, of hormones, and things like vitamin D. And of course, without it, our bodies couldn't function. That being said, the vast majority of the cholesterol circulating in the blood isn't something we really need. It's mostly made by our livers. Approximately 20% comes from what you eat, dietary, mainly from saturated and trans fats in foods. But it's important to recognize that even if we eat properly, our livers make more cholesterol that circulates in our blood than our arteries would like. And dietary cholesterol doesn't affect blood cholesterol levels to the same extent in all individuals. And finally, while our body, of course, needs cholesterol, the cells can manufacture their own cholesterol, so they're not dependent on the circulating blood cholesterol levels. For some unknown evolutionary reason, we are typically born with low levels of the bad cholesterol, also known as low density lipoprotein, or LDL-C, LDL cholesterol. Perhaps in part because we become a little bit more couch potatoes than our former ancestor hunter-gatherers did. But unfortunately, our cholesterol levels tend to rise and fairly soon after birth. And maybe way back, there was some value to having extra cholesterol. Perhaps our earlier ancestors didn't eat, 3 meals a day plus snacks in between while chasing or being chased by something like a saber-toothed tiger. But in contemporary times, LDL cholesterol floating through the bloodstream, much higher levels, and it's really considered a junk protein that doesn't serve any clear purpose and unfortunately causes atherosclerosis. Now, this is a little bit of an oversimplification, but cholesterol is transported in the blood in tiny protein jackets called lipoproteins. And of course, 2 of the many major lipoproteins include things that people are probably familiar with. I've already mentioned low density lipoprotein, or LDL cholesterol, considered the bad cholesterol. There's also something called high density lipoprotein, HDL cholesterol, which in general is considered to be a good form of cholesterol. Now, epidemiology, or population-based research, has clearly demonstrated to us that cholesterol is a causative factor in the development of atherosclerotic cardiovascular disease. In other words, the higher a person's cholesterol level, the higher the risk of developing and dying from atherosclerotic cardiovascular disease. In contrast, randomized clinical trials have assessed different classes of LDL cholesterol drug treatments like statins, ezetimibe, and more recently, PCSK9 inhibitors. And they've shown us that we can safely and effectively lower LDL cholesterol levels, and that can translate into a significantly lower risk for developing atherosclerotic cardiovascular disease or having an atherosclerotic cardiovascular disease related event, including dying from that. For example, with these very safe and effective treatments for high levels or unhealthy levels of cholesterol, LDL cholesterol, for every 1 millimole per liter absolute reduction in LDL cholesterol, we can realize about a 20% relative lowering or reduction in experiencing an atherosclerotic cardiovascular disease event, like a heart attack or like a stroke. Now, this is a graphic that illustrates a timeline of atherosclerotic plaque formation. The main initiator of atherosclerosis is actually inflammation. Inflammation leads to something called endothelial dysfunction. The endothelium are the cells that line our blood vessels. And when they aren't working properly, that's when cholesterol floating around in the bloodstream can get into the walls of the arteries. And so cholesterol accumulates, and over the course of time can progress to things called foam cells, to fatty streaks, to fibrous plaques in the walls of the arteries. And plaques are dangerous because they can rupture, they can erode, they can ulcerate, they can be penetrated by cholesterol crystals. And once the contents of the plaque are exposed to our blood, that leads to a cascade of events that leads to the formation of clots. And clots can, in an attempt to heal up the situation, can actually do more harm by causing complete or incomplete blockage or occlusion of the artery, and then that can lead to things like a heart attack or a stroke. So what are the consequences or the further consequences of the development of atherosclerotic plaques in the walls of our arteries? So as seen here, the narrowings or blockages that form in the walls can then lead to a restriction in blood flow. That restriction limits or prevents the red blood cells that carry the oxygen and the nutrients from reaching the vital tissues like the muscle and the heart or the brain, for example. This is a depiction of some of the major clinical manifestations of ASCVD. So there is cerebrovascular disease, like a transient ischemic attack, a sort of warning of a stroke, or an actual stroke that can happen in the brain, where people can have troubles with brain function. They can lose the capacity to move or sense something, or their speech may be impaired in some way. People can also have coronary artery disease, where people can have chest discomfort or breathing difficulty. We typically call that angina. Or if there's prolonged blood flow blockage, permanent damage to the heart muscle, as I've mentioned, a heart attack or a myocardial infarction can occur. And because atherosclerosis can affect the entire bloodstream throughout the body, we can't forget that people can also get narrowings or blockages in the arteries, for example, leading down to the legs. And sometimes people can experience a restriction in blood flow and get something called claudication, which is a sort of cramping that people get in the back of the calves when they go for a walk. Not the type that wakes you up in the middle of the night, but when they do something with the muscles in their legs, and that's called claudication. And in more severe cases, peripheral artery disease can lead to resting pain and a very critical lower limb ischemia, not enough oxygen getting to the tissues, necrosis, which is actual damage, including something like gangrene. So I just want to finish up to talk about I'm really convinced that the best way forward is what we're just describing here and participating in as part of the Global Heart Hub. I think that the way forward, we need to engage the individual, the patient and their family. We need to move away from the paternalistic physician-only approach. We have to engage all of the healthcare providers, not just the cardiovascular specialist like me, who happens to see a patient with atherosclerotic cardiovascular disease for 3 days in the hospital when they've had their heart attack. We need to engage both the in- and outpatient-based pharmacists, nurses, nurse practitioners, dietitians, nutritionists, the patient's primary care provider. This is a team sport to be able to empower the patient and their families so that they can be their own best advocate. So we have the tools, and now we have to coordinate how best to use them, because I think this is a winnable fight against high cholesterol and atherosclerotic cardiovascular disease. Thanks for your attention.
Thank you very much. And after such as setting out all of the health impact of cholesterol, to end it on that very positive note, to say I think this is a winnable fight, was extremely, that was inspiring. It was nice to hear after seeing, just how much damage can be done over time if we're not addressing this. So now I'd like to invite Chantequillette Carter, who's going to talk to us about the realities of being a patient experiencing these things. Now, Chantequillette is the founder and executive director of the Pink Peppermint Project, and she's going to share the stories that she has from her life of experiencing this and trying to respond to it. Chantequillette, again, I know you've got up very early to talk to us, and we very much appreciate it. Please tell us your story.
Yes, hi everyone. I'm Chantequillette Carter Williams. I reside in Dallas, Texas, and I was diagnosed with ASCVD back in 2019. However, it was not a very short diagnosis. I actually had a delayed diagnosis, starting with symptoms back in 2012 after just running on the treadmill and feeling some heart palpitations, and not really knowing what that meant, but knowing that there was something wrong and that I needed to get it taken care of. I went to the doctors, And at that time, I was given a stress test and told that I had some exercise-induced arrhythmia, and that I should just, monitor my heart and make sure that when I'm exercising, I don't overexert myself. However, for the next 8 years, I was in and out of ERs, doctors' offices, trying to find out what was going on with me, with little to no explanation from doctors other than, hey, you need to just work on, not working out so much. So when you don't work out so much, what happens? You start gaining weight, you become unhealthy. And it was frightening because I was someone who was very, very active before I started having those issues. And so because I did not actually know, one of those huge factors is that I didn't know my family history. I did not know that my dad was also battling with high cholesterol. I did not know anything about LDL levels. Doctors didn't talk to me about LDL levels. So it was kind of scary when you're kind of living in the unknown, especially when prior to that, there were no, underlying issues. Just out of the blue, you just, start feeling unwell one day. Leading up to these issues that I was having with my health, I went to work one day, was not feeling well for, I want to say a couple of days. And that's when I had my first myocardial infarction. I hope I said that correctly. I had my first myocardial infarction. And at that time, I was still told that it was related to stress, and that my job, I'm a retired tax accountant with the IRS. So it seemed like doctors was putting it all on me versus just, really getting down to the root of what was going on with me, doing the necessary tests. And so as they were telling me these things, I was doing my best to try to make the necessary changes so these things wouldn't happen again. It's unbelievable. I did not, after a myocardial infarction, I did not have a heart cath. I did not have echocardiogram. I didn't have any of those things. I had a stress test and told, hey, you either need to quit your job or, this is pretty much going to be your life working with the IRS. And that's what I did. My job made all the accommodations they could for me. It appeared to relieve it for a temporary time, but things started to develop and get worse, where I had my first stroke into April of 2019 at work. After shortly 2 weeks after having 2 weeks before that, having a heart cath, telling me that everything looked okay, other than I had a mild, I don't know if I can say the diagnosis, but there were mild issues that I was told that I shouldn't worry about. The day before my stroke, I was released from a cardiologist, was in the cardiologist's office saying everything looked good. There were some questions that I had about some things that were on my test and that he wasn't aware of based off of what another doctor said. And he's like, oh, okay, well, we'll give you some more tests. Well, those tests were able to happen before I was supposed to have I believe a doctor's appointment on the 11th of that week. I had my stroke on the 9th. So I ended up getting a really good neurologist at that time. And she was able to do what I want to say 12 doctors did it. She ran every test that she could. And when they found out that my LDL levels, which I didn't even know what that was, she's like, has anybody ever told you that your cholesterol is extremely high? And I'm like, no, nobody's ever even mentioned that to me. And I was at that time diagnosed with ASCVD. Once I learned that diagnosis and started talking to my family members, that's when I learned that my dad was also dealing with high cholesterol, ASCVD, and taking statins. Nothing that I even knew about, which I think would be a huge factor in me when talking to doctors. I don't 100%, blame it all on doctors. I feel like if I was able to communicate, that information that, my dad is, has high cholesterol, then they would have made the connection and said, maybe this is something hereditary that I'm going through, and maybe they would have dug deeper. So now I make it my goal to make sure that I'm a voice for my community, because I know in my culture, we kind of, there's this what we call secrecy when it comes to our health, and we don't like to disclose things that essentially can help others. So for me, that's really important, to make sure that my kids know their family history, they know their health history, and that it will prevent them from running into the issues that I had in the past. And that, if anything, I could have been put on medication, 10 or 11 years, 7 or 8 years before I actually had my stroke, and it may have prevented it. So I really think that what we are doing here, what you all are doing here at Global Heart Hub is really amazing and needed. And that it would, increase the quality of life when it comes to people like me, and making sure that we take care of our health. For me, my life has changed. I had to retire. I had to retire from my job. It really impacted me. I want to say in a negative way, but also in a more positive way, because I'm here today talking to you all and doing a lot of amazing things since my stroke and heart attack. So I really, really thank you all for having me here. And I look forward to what you all are doing to make sure that we all, live healthy lives, and we all are accountable when it comes to ASCVD.
Thank you so much, Shanti Quillette, for sharing your story and being very honest about all the different ways where, those interactions between some of those different doctors might have been different if you'd known your story, if they'd known what to look for, if it was better known, and that, the key marker that should have said a red flag, the cholesterol, wasn't picked up at any of those stages because they didn't know what they were looking for. They didn't expect to see it, and so nobody looked for it. So thank you. That was really helpful to share the experience of what that's like as a patient going through a system that's not sensitive to these issues. So thank you, Shanti Quillette, and we'll come back to you later when we have the Q&A. And a reminder to our audience, if you've got a question to a member of our panel, please submit it through the Q&A function, and then we'll be able to put those questions to our panel. Our next speaker is Professor Fausto Pinto, who is the president of the World Heart Federation, and he was with us yesterday and had a chance to talk to you. Unfortunately, he's actually in an airplane at the moment, so he's unable to present to us live, but he's very kindly recorded a video with his message. So with his best wishes, here is his video message. Let's watch it.
Hello, my name is Fausto Pinto. I am the current president of the World Heart Federation. And I'm delighted to be here with you today on the launching of a global cholesterol action plan and share with you what we are doing at the World Heart Federation, particularly the cholesterol roadmap, which we launched just a few weeks ago in Rio de Janeiro during the World Congress of Cardiology. Let me just give you a few words on the World Heart Federation. We are an umbrella organization.
Apologies, we just need to make sure that we've got our technical
including
ducks lined up in a row to make sure that we can do that. Can we show Dr. Pinto's video,
we work
please?
through connecting, leading, and inspiring the cardiovascular community, translating science into policy to influence agencies and governments, and stimulating the exchange of information to achieve our goal of cardiovascular health for everyone. The roadmaps have been developed over the last few years on different topics, from air pollution to atrial fibrillation, to more specific conditions such as Chagas disease, and now also on cholesterol. What is the rationale of a roadmap? Well, we know that cardiovascular disease remains the main cause of mortality and disability at the global level. We know the causes. We do have cost-effective treatments, but there is still a large evidence gap in terms of implementing what we know and what are on the guidelines on the ground. And that's the reason why we created the concept of roadmaps. So basically, roadmaps, they are global frameworks informed by evidence, health system and policy approaches oriented towards action. The second goal is to assist the leaders in cardiovascular health to assess the needs and the gaps in their communities. And thirdly, to identify the roadblocks and suggest evidence-based solutions that could be relevant in different contexts. Well, here we can clearly see that there is, unfortunately, an increase in the percentage of mortality, in the mortality rate across the globe regarding cardiovascular disease. So 80% of cardiovascular deaths in low and middle income countries. You can see the trend, which unfortunately it's increasing. This is data taken from our observatory, the World Health Observatory, which we launched this year also in February. Here you can see global death rates from ischemic heart disease attributable to dyslipidemia. And you can see there are some differences in terms of the different impact in different parts of the world. But in 2017, high non-HDL cholesterol was responsible for an estimated 3.9 million deaths. And this is really a big impact in terms of cardiovascular health. Here you can see also the change in standardized mean non-HDL cholesterol between 1980 and 2018 by region and for women and for men. And you can see here the distribution across the different parts of the globe. The use of statins in low and middle income countries, the WHO target was at least 50% of eligible individuals to receive statin therapy to prevent cardiovascular disease. Well, we can see that the use is very low in the low and middle income countries, 8% for primary prevention, about 22% for secondary prevention. So if we look at the reasons why it's important to look at the health system building blocks, we can look at service delivery, health workforce, information, medical products, vaccines and technologies, financing, leadership, governance, and then look at access coverage, quality, safety, and translate that into improved health, responsiveness, social and financial, risk protection, and finally, improved efficiency. So if we look at the health system roadblocks identified, you can see here different ones, from lack of governmental policies and infrastructure for prevention of atherosclerosis cardiovascular disease, lack of or suboptimal screening programs, environmental barriers to lifestyle modifications, shortage of facilities for large-scale measurement of blood cholesterol levels, and so on. So many, many different roadblocks that we can identify, and they were identified in our roadmap in the health system. Again, here you can see the availability and free prescription of these treatments. And that's why we can now look at what we've done in our roadmap, basically focusing on 5 different focuses. The first one on improve awareness. The second one on roll out population-based approaches to prevent atherosclerotic cardiovascular disease and reduce population-level cholesterol exposure throughout the life course. Thirdly, to reinforce atherosclerotic cardiovascular disease risk assessment. 4, implement number 4, system-level approaches targeting specifically high-risk individuals. And 5, establish national and regional surveillance of cholesterol and atherosclerotic outcomes. So if we focus on focus 1, which it's about improving awareness, you can see that it focusing on advocacy, promoting advocacy through greater interaction of different patient organizations with healthcare professionals and the policymakers, partnerships, and education. The second focus is on population-based approaches, support food reformulation efforts, in particular regarding eliminating artificial trans fat, deliver education in terms of unhealthy dietary patterns with focus in reducing consumption of ultra-processed and healthy fat-containing foods, and finally enforcing adequate taxation policies on unhealthy communities and allocating these revenues for advancing prevention and control of NCDs. The third focus, which is on risk assessment, population screening for genetic dyslipidemias, we are focusing on setting up point-of-care testing with inexpensive and easy-to-use technologies, allocate sufficient resources for screening and diagnosis throughout the life course. Governments encouraged to consider universal child-parent screening for familial hypercholesterolemia and Lp(a) and cascade testing of first and second degree relatives. And finally, referrals to tertiary facilities for patients with severe forms of FH, like homozygotic FH, or patients with refractory to standard lipid-lowering therapies. And focus 4 on system-level approaches for high risk, ensure the affordability of essential cholesterol lipid-lowering medicines, support the use of polypills among certain high-risk groups, and support engagement of non-physician health workers to increase adherence to drug therapy. And finally, focus 5 on establishing surveillance of cholesterol and atherosclerotic cardiovascular disease, collect epidemiological data to provide data-driven policies and assess the impact, support development of FH registries, use of technology linking patients, pharmacies, and healthcare professionals, and finally, to monitor stock outages for essential medicines such as statins. These are the 8 pillars of the cholesterol roadmap. 1, atherosclerosis results for the retention of apolipoprotein B, ApoB containing lipoproteins with cumulative effects over lifespan. 2nd, multifactorial disease. 3rdly, most atherosclerotic cardiovascular disease events occur among individuals without extreme elevations in LDL cholesterol. 4th, FH is more common than imagined, the importance of screening and treatment. 5, atherosclerotic cardiovascular disease can be reduced by LDL lowering by multiple different pathways and benefits proportional to intensity and duration. 6, LDL is still the therapy target among ApoB containing lipoproteins. 7, increase in obesity and diabetes means increasing in atherogenic dyslipidemias. And 8, elevated LP little a. It's common but poorly detected, and we know today it's an independent causal risk factor for atherosclerotic cardiovascular disease. So if we look at the implementation of our roadmap, we focus on roundtables at the national and regional level. We conduct situation analysis to understand local situation, and then we include multiple stakeholders led by WGF members, governments and policymakers, healthcare professionals, academic and research institutions, NGOs, health advocates, private sector, adapt and select relevant WGF roadmap solutions to local context, and finally define and implement an action plan. Here you can see different cholesterol roundtables that have been organized around the globe. So in summary, I would say that the adverse effects of LDL cholesterol and ApoB exposure are cumulative and result in atherosclerosis cardiovascular disease. Secondly, preventive strategies should start early in life. Thirdly, there are effective and safe lipid-lowering treatments. There is a substantial gap in implementation of effective strategies and treatments, and that's why we need an holistic health system approach, which is urgently needed. We have our roadmap has been published. There are toolkits that are now available. And I end by saying that the WGF, we very much support this Global Cholesterol Action Plan that is today launched by Global Heart Hub, one of our members, activating change to reduce the impact of unhealthy cholesterol levels. And with this, I will finish. Again, thank you so much.
Thank you very much for that presentation by Professor Pinto, setting out the World Heart Federation's cholesterol roadmap and seeing how that connects into the action plan that we're speaking about today. And he highlighted again some of the different challenges that exist and to see ways that we can resolve them. So now I'd like to pass the floor to Neil Johnston, the Executive Director of the Global Heart Hub, and he's going to take us through what are the key elements in the action plan and what do we need to make it happen. Neil, the floor is yours.
Sorry,
Neil,
yeah, sorry, you can hear me now?
Now we can hear you.
Share slides here. Bear with me now. Can you see my slides now? Very good. So thank you very much. And just to recap to this point, we've heard very clearly from Dr. Sean precisely what atherosclerotic cardiovascular disease is. And we've heard from Chantal very much what the lived experience can be like. And as a patient organization, we know more than anyone else the impact of cardiovascular disease. And we learned perhaps just how devastating underlying cardiovascular disease can be in the context of COVID. And through that experience, over the last 12 months or so, the Global Heart Hub has been working on a program which we call Invisible Nation. And the concept is that there's an invisible nation across the world of individuals living with atherosclerotic cardiovascular disease, and we need to put a spotlight on that. And in our journey on Invisible Nation, we have realized that we need to really implement and take some action. And to that extent, today, we're really excited to launch our global action plan on cholesterol. So to take a minute to frame the scale of the problem, ASCVD accounts for 85% of all cardiovascular related deaths, and has already been indicated, it's the leading cause of mortality worldwide, responsible for more than 15 million deaths each year. So this is a very serious public health issue, and these are very alarming statistics. Many people will know the term that Dr. Sean has referred to about bad cholesterol. The clinical term is low density lipoprotein cholesterol, LDL-C. And we now know that the longer a person is exposed to sustained LDL cholesterol levels, the higher the risk of developing ASCVD, and therefore of having severe a severe cardiovascular event. For most people, high levels of bad cholesterol can be reduced by modifying certain lifestyle factors, such as their diet and physical activity. But for some, as we've heard, it's an inherited condition with levels of cholesterol much higher than that of the general population. And that's known as, or referred to as, FH, or familial hypercholesterolemia. So I'm not being alarmist when I say we are facing a crisis. We are in a crisis, actually, in the context of cardiovascular disease. And ASCVD has a number of contributory factors, but the most predominant of these is uncontrolled cholesterol. And unfortunately, the extent of this is underestimated by people themselves and by society and by our governments and systems that are managing our healthcare system. And what is most dangerous is that ASCVD is a slow burning, insidious, invisible condition, and it's on the rise. And the impact is far reaching, and the burden weighs heavily on healthcare systems. So you've just heard from Professor Pinto's presentation that the World Heart Federation has just launched a roadmap for cholesterol, an updated roadmap. And we thank the World Heart Federation for their hard work. And as a patient community, we now are, through this global cholesterol action plan, are ready, hopefully, to implement the change that's called out here. So I'm delighted to share with you today some very important news, and that is that we are unveiling today a global cholesterol action plan. And this action plan represents the voice of the global patient community and was created with the support of the Invisible Nation program, which we launched just over a year ago to expose the realities of ASCVD. So the action plan has 4 very clear goals with one overarching objective, and that is to ensure unhealthy cholesterol levels are addressed as a public health priority. And each goal is associated to actions to help the community achieve the goals. So I'll walk through each goal and the various actions. So the first goal we hope to establish, we hope will help us establish the foundation for change, because we do need to change the dialogue, the mindset around cardiovascular disease, ASCVD in particular. And we understand that to create change, we need the support of a community. To that end, the first goal is calling on the creation of country or regional alliances, a ground-up approach. And the call for alliances is to include multi-stakeholders to ensure that the patient is represented by many voices, and that governments will eventually take notice that addressing unhealthy cholesterol levels is not something that should be exclusively led by patient organizations. The second goal is to bring public attention to the risks associated with unhealthy cholesterol levels. ASCVD, as I mentioned already, is largely an invisible disease. The symptoms are silent as the plaque builds up over time. And people don't realize it's happening until the plaque in the arteries unexpectedly ruptures, causing a heart attack or stroke. So we need to move the public mindset, and we need to do that by education. And anyone living with cholesterol should be made aware of what are the unhealthy levels that are putting them at risk and how they manage to reduce that risk. because we know that most people are not aware of their risk. The next goal is about activating change. So we have a problem, which is ASCVD, and now it's time to gather our collective strength to advocate for change. Understanding that some groups and alliances will need to acquire skill sets, particularly in the patient community, we in the Global Hub are hoping that we will be able to provide the necessary advocacy training to move the dial forward in this discussion. It will be critical to share country or region level evidence with governments so that they understand the scale of the problem and the overwhelming burden on patients and healthcare systems. The fourth and final goal is the single most important goal. Despite existing programs in place across the world, ASCVD still remains a global problem. The key to addressing the current state is to identify where the gaps are and implement approaches that will change the status quo. So the goal is to activate change, ultimately with government and policymakers. So the Global Heart Hub is committed to drive this forward, to deliver as best we can this action plan, but we can't do it alone. We need engagement to deliver change across the globe. So today we're calling on our patient communities and all other stakeholders around the world to help us build a momentum. So whatever role you can play, we welcome you to join us on this endeavor. And I'll leave you with this statistic that 80% of premature cardiovascular events can be prevented. And that is a really, a damning call to action, if you like. And when you consider that, if you look at, for example, risk factors like smoking, we were for a long time aware of the damage of cigarette smoking. And eventually it took a groundswell of public opinion to, I guess, realize that we needed to regulate smoking, access to smoking, and so forth. And a multi-layered approach to addressing the risk of smoking has resulted in significant health benefits. And we need to look at cholesterol now in the context of something that is a slow burn, insidious disease, high cholesterol. And we really need to get to a point where ideally everyone is aware of their cardiovascular risk with cholesterol. And we're looking at trying to reduce lifetime exposure, because that's really what it's about. I think traditionally we used to think that it was about getting a number and trying to keep that number below a certain target. Yes, there are targets, but we need to realize that it's a lifetime exposure to cholesterol here that results in the negative outcomes. So we need to do as much as we can to keep cholesterol levels as low as possible at a population and individual level.
Thank you very much, Neil. And I think you ended on some very important issues, not least this idea that, looking for the golden bullet of the one number that we should aim for is not the area to look at. It's reducing the lifetime exposure. And I'm very much struck by that. And again, in the presentation that Sean, he showed us the sort of artery, how over time, each decade, that artery was getting more clogged and the sort of passage for the oxygenated blood cells smaller and smaller. And it's this lifetime exposure issue that we might need to pick up on. So I'd like to say thank you, Neil, for sharing the key elements in the action plan. I'm going to invite the panel now to help us discuss what we can do. But Sean, let me start with you. What's from you're a clinician, you see patients all the time. You've just heard this action plan. How do you think this could change things?
Well, having been in practice for about 30 years now, I've seen multiple attempts over the years to try to galvanize all of the stakeholders, but nothing quite like I've seen in the last year or so with a Global Heart Hub in terms of engaging all of the stakeholders. the opportunity to share the stage, so to speak, today with someone like Shanta Collette is so powerful, is so inspirational. We can't do this as, for example, the physicians alone. We can't do this as government alone. We need to get all of the stakeholders, all the partners together. As you've heard repeatedly, we need to hear these stories. We need to enhance the awareness. We need to, of course, raise general public awareness, and our politicians and policymakers have a responsibility to the public to recognize this invisible nation and how impactful this is on people's quality and length of life. And so I'm really optimistic and hopeful that this plan, which, as I say, includes alliances with all the stakeholders and activating all of the stakeholders, empowering all the stakeholders, I think that that's going to be the way forward, and it's going to change, hopefully, the trajectory that, from my perspective, has been kind of flat over the years, and hopefully get some momentum to move this important topic and issue forward.
Thank you. Shanta Collette, maybe I'd like to invite you to respond on this. We've heard from Sean that there's really finally some momentum starting to happen, which is quite exciting. But I wonder if you want to comment on the fact that I suppose the popular idea is that cardiovascular events happen to older people. People in their 50s and upwards. That's generally when you expect people to maybe get their cholesterol checked and everything else. How do we address this issue that Neil talked about, which is the lifetime exposure, that it's something we should be aware of and be tracking from quite young ages? And I'm not quite sure exactly how young we should be looking at that. But certainly by the time you were old enough to hold a job and be in a gym, it's something that should have been on the radar of the physicians treating you. Have you found that people were really surprised that you experience this condition that most people expect happens much later in life?
Yeah, absolutely. The first thing people say when I say I've had a stroke or a heart attack is that you're really young, and they always think, it's for kind of like what the doctors did. Well, what were you doing? Were you unhealthy? Were you this? Were you that? And it's really not about that. It's it's from genetics, it's healthy lifestyle, it's all these things. And I think it should be something that should be spoken upon as little as, once you start PE, you see athletes, you see young athletes collapsing. Our older community, it can essentially happen to everyone. And if there is that genetic component, then it really needs to be emphasized as soon as you know that you have someone in your family who does have a heart condition or maybe battling with something similar.
Thank you. And from your example, it sounds like we need to have a lot more very open and frank conversations within our families to understand, what the risks are, what uncles and aunts and cousins and nephews have, so that we've got this sharing of information, because it's that family inherited risk that's the hidden one, I think, that would be so difficult to uncover. It's the one that, when a doctor sees you and you were young and healthy looking, that they just didn't see what was behind that, which is the family risk.
Yeah, it's funny that you say that, because once I had my stroke, I had found out that 4 of my first cousins have, I have a cousin that had a pacemaker. I had a cousin who had some pulmonary issues. And so no one was discussing this. And it's like, oh, if I would have known this before, I could have said, my dad, my cousin, all of us have heart issues. And the doctor would have been like, okay, well, let's do some invasive tests. Let's put you on some medication. Let's do, all these normal, these things that we wouldn't do had you not said all these things. So I think it's really important, especially culturally, that those conversations are more open, that we know our family history, our risk, and all those other things that incorporate to a healthy heart. Thank you.
Neil, your campaign is linked to this invisible nation that you've called it, just as we've heard from Shanta Collette, that actually often the families may have this, but it's hidden, and you've called it the invisible nation. How do we raise awareness and change the perception in people's minds that cardiovascular disease is something that happens to older people as a result of, their unhealthy lifestyles, but really sort of highlight that it's a much broader risk and much of it's preventable, and that the things people can do. Are we saying that you should start from their teenage years? Are we saying it's school? Where if you sort of follow that path, what's the earliest point we should be intervening?
So a couple of things on that. I think the invisibility piece, first of all, relates to the fact that there's this insidious burden of plaque development happening, and eventually it erupts and you have a cardiac event. But there's also an invisibility issue, I guess, from the point of view of public understanding, because by and large, when we think of a cardiac event, whatever that is, whether it's a cardiac arrest, heart failure, the general public just view that as a heart event. What we're trying to draw attention to here is that in the family of heart events, the biggest contributor to the biggest burden is the biggest burden being atherosclerotic cardiovascular disease, is actually the cause. Atherosclerotic disease is the cause of the greatest number of heart attacks and strokes. So the biggest issue in the family of cardiovascular diseases is this buildup of plaque. Cholesterol is one of the primary factors here. There are other risk factors, but it's one of the primary factors. And so the first thing is, at a very simple level, we now know, the science can tell us that the higher your cholesterol level, the greater your risk. And the longer you're exposed to a higher level, the greater your risk. So in simple terms, if we were able to reduce the overall levels of cholesterol in a population in the same way as we reduced the number of people smoking, you reduce the burden of the disease. Now, so there's an education piece. That's the first thing. The second piece is that clearly, as part of the process, you also need to be looking for it. Okay, so you need to, and we obviously can't, go out and screen every single person in the world on the basis that they might have high cholesterol. However, we do know that in the cases of the genetic forms of high cholesterol, FH, for example, that there are some countries, take Slovenia, for example, where they now, at the age of 5, have a national screening program for high cholesterol. And as a result of that screening program, they now have detected 91% of FH cases. So there is a case to be made for a cholesterol screen in childhood. And if we were in an ideal world, and maybe Sean may have some views on this, if you had in an ideal world, you had early childhood screening for cholesterol, and then based on risk profile, maybe at 2 or 3 critical points in life, revisit the cholesterol profile, you would make a major step forward, because we also now have the therapies to reduce these levels. So we know the answers, but what we're missing are the systems and the processes to actually implement this reduction program. Maybe Sean would like to comment on the screening.
Yeah. Thanks, Neil. I'd just like to add to that. Absolutely. The question of screening is still debated, and there's no magical number. In Canada, our experts have recommended that any man or woman who at the age of 40 or older should certainly have a screen. But for people that are younger than that, we look at other so-called risk factors. So, of course, a family history of high cholesterol warrants earlier on, and Chantal Colette's situation with an inherited familial hypercholesterolemia situation, we advocate, we suggest that once that's identified, there should be something that we call cascade screening, which means that even in one's children, that there should be a check, because we don't want to wait until age 40, or we don't want to wait until somebody has a heart attack or a stroke to identify that they've got this high level of cholesterol. Women who have higher than usual blood pressure during their pregnancies, even though they're maybe well under the age of 40 when that happens, those are individuals that need a screen. We can't forget that there are so many different people, those who are smokers, those who have diabetes. There are all kinds of things that even earlier than that, not so magical age of 40, that we have to consider. And as Neil, made the point so nicely, this is, an accumulation over the course of time. It's the amount of LDL cholesterol, for example, that's floating through the bloodstream that's allowed to get in to the walls of the arteries cumulatively over the course of time that sort of adds up. And again, we don't want to wait until somebody has a heart attack or a stroke to be able to identify that particular risk factor, especially since it's so easily treated very safely, and it can make a huge difference in that trajectory that we talked about of the accumulation of cholesterol in the walls of the arteries, atherosclerotic cardiovascular disease.
And Tamsin, if I can just add to that, I think it's important as well that we don't just leave people thinking that the solution to this is to just go and screen the world, because there are a lot of other steps that have to be taken in reducing this overall burden. And the World Heart Federation roadmap calls these out. And I mean, this is at the level of societal change in terms of the food we're eating, because yes, you may argue that food and diet is a personal choice, not always the case. And there are, so many social determinants of our health, and these need to be considered. So for example, there are foods that have ingredients which are clearly, bad for one's heart in simple terms. And so there needs to be regulation of those. We have regulation in other walks of life. For example, in construction nowadays, asbestos is illegal. So why aren't trans fats illegal, if you will? And so the risk factors here are varied. Cholesterol is clearly potentially the strongest risk factor in ASCVD, but it's not just about screening. Screening is one part of the solution.
Thank you. And I wonder if you might want to just tell us, when we talk about screening, what are we talking about? Do people need to just take a simple blood test? Is it, a little pinprick? Do we need hospitals and labs and facilities? Because if we start talking about screening, let's try to understand what it is that's involved.
Maybe I'll take a crack at that first. The first step would be to make a connection with your primary care physician, with a healthcare provider, to go over what your history is, what your family history is, to do a physical examination, to check your blood pressure, a simple measure. Of course, that can be done at home now. That can be done in a pharmacy. It doesn't have to be restricted there. But I think it is good to engage a healthcare provider if possible, to then look at some of the other parts of screening, which would include a blood test. There are, as you mentioned, a sort of finger prick, a test that can be done as well. So, but a simple blood test, which doesn't have to be fasting, like it was always done in the old days. So this can be done at a convenient time for people, and checking on the simple cholesterol profile, often to check the kidney function, a simple blood test related to that, and to check the sort of sugar status to make sure people don't have diabetes sort of hidden underneath. Those would be the sort of first quick steps to be able to make an estimation of the person's risk for developing atherosclerotic cardiovascular disease, which would of course include a cholesterol assessment.
Thank you. Neil, do you want to add to that?
Yeah, I mean, Sean has obviously explained what's involved in screening, but if I might just revert to what we're trying to achieve here in terms of our action plan, the picture is quite simply this. ASCVD is a major public health issue. The flames of ASCVD were fanned by COVID. So now more than ever, we need to realize that we need to tackle the burden of ASCVD. We need to identify this invisible nation, and we need to intervene. And the good news is, if you will, that we know what causes this, and we can treat it, and we can reduce this burden. What is required is a collective action, individually, systems, healthcare professionals, But ultimately, we're going to need government policies and strategies. That means at a national level, actual cardiovascular health strategies which call out prioritization and prevention of ASCVD. And that's why this action plan is a ground-up movement. The World Heart Federation has, convened all the experts. It has laid out a roadmap. And now we're calling on the patient community, on the public, on the citizens of the world to come together and say, enough is enough. This is something that we know many people in our families who've been affected by it. Many families have lost someone through this, and we can stop it. We can make a huge difference.
Thank you very much, Neil. And we've come to the end of our time together. And I want to say a very warm thank you to Sean, to Chanticleer, to Neil, and of course, Professor Fausto, who is in the airplane right now, but managed to send us a video. Thank you very much. As you said, this is hugely preventable. We can do something about it, and it affects a huge number of people. So let's follow up with the roadmap and the action plan. So thank you very much. We're going to now have a short break, and when we come back, you need to go back into the main room because there will be a final session where we're going to explore how cardiovascular patient representatives can achieve political impact, which is exactly what we've been talking about in this session. So I look forward to seeing you in 10 minutes. Thank you.